Good morning, everyone. We welcome you to our IC on small incision lenticle extraction. So we'll cover the talks in series, and I'll be starting with the initial talk focusing on decision making and patient selection. So I'll be covering understanding the machine and laser settings and preoperative case selection and patient counseling. There are no relevant financial disclosure. So small incision lenticle extraction has gained popularity since its introduction owing to a lesser adverse effects on the ocular surface, less dry eyes, and greater biomechanical stability. However, it is definitely more challenging to perform than conventional lab-based procedures that we were used to earlier, with lenticle dissection and extraction being very challenging and an experience of at least 80 eyes required to perform SMILE consistently in less than 5 minutes. So what's important is to understand the machine and laser settings and optimize patient selection to help achieve consistent good outcomes. So there is a treatment pack in SMILE, which is a single-use disposable contact lens with attached tubing. The patient interface is based on attenuation rather than applanation as in LASIK. And there are three sizes, small, medium, and large. Generally, the Indian population is suited to a small size of patient interface with a 11.2 wide to wide diameter. The Visumax femtosecond laser system employs a 1043 nanometer femtosecond laser with a pulse duration of 220 to 580 femtosecond and a frequency of 500 kilohertz. So there are three modes of treatment: standard, fast, and expert. Standard is the default parameter set by the manufacturers. The fast mode may be altered only by the application specialist and consist of preset laser parameters that may be customized as per the region, and then you can use the fast mode in your cases. Expert mode allows surgeon control over the machine settings, and within a certain range the surgeon can modify the laser parameters. It is advisable to always consult the application specialist before trying to alter the laser and energy settings. So, what do we understand by the different parameters that are displayed on the screen while planning treatment? Spot spacing is the distance between two adjacent laser spots. It ranges from 2 to 4.5 micron, and you may modify it in the expert mode in steps of zero point 0.1 micron to a maximum of plus minus zero point 0.5 microns. Track spacing is the distance between two laser spots in adjacent tracks. It ranges again from 2 to 4.5 micron and is modifiable in steps of 0.1 micron to a maximum of 0.5. Scan direction is the direction of the spiral that the laser follows while making the cuts. It's spiral in for the posterior plane and spiral out from center to outwards for the anterior plane. Scan mode is preset as single, which refers that the entire lenticule is created in one go. Pulse energy is the size of the cavitation bubbles which are produced during laser cuts and range from the 100 to 260 nanojoules, and recommended is between 100 to 160. So one energy offset is equal to 5 nanojoules, and we keep the offset in between 20 to 32. The expert mode allows the surgeon to modify the energy offset by a total of 6 steps in either direction. So total of 30 nanojoules energy can be modified in either direction. So how does modifying these laser and energy settings work? If you decrease the spot and track distance, the spots and tracks are placed closer together, so there will be smoother cuts. However, more energy is delivered. Vice versa, if you increase the spot and track distance, they may have more adhesions and less smooth cuts. However, the total energy delivered also decreases. If you decrease the pulse energy, less energy leads to faster visual recovery and better quality of vision. However, more adhesions may be present. So it's a fine tuning basically of having the least amount of energy to give the smoothest cuts and minimal adhesions, which you gain with experience. So this is just a summary of the three different modes available: pulse energy, energy offset, track distance, and spot distance. So the track and spot distance for the lenticle and cap cuts, it's generally around 4 to 4.5 microns, and for the side cuts, it's kept around 2 microns. These are the cap parameters. The cap thickness ranges from 100 to 160. We usually keep around 120. Now people are experimenting with thinner caps as well. Cap diameter is conventionally 1 millimeter more than the lenticule diameter. Incision position can be placed anywhere. Conventionally, it's placed generally slightly superotemporal for the right-handed surgeon, around 110 degree. Incision width varies from 2 mm for experienced surgeons to 4 mm for beginners. Cap side cut angle is conventionally cut 90. And lenticule diameter ranges from 6 to 7 mm. Transition zone of 0.1 mm is preferred when you have a cylindrical error. It's 0 if you have a pure spherical error. And minimum lenticule thickness refers to the lenticule edge thickness, and it should be kept at least 15 microns. And if you have a very low myopia, you may keep it higher in initial cases. And lenticule side cut angle varies from 90 to 135 degree preferred. So coming to patient selection, so this is our review article on in clinical ophthalmology regarding patient selection and perspectives. So preoperative preparation is essential. So what comprehensive history, ocular examination, investigations, and patient counseling should be taken into account before going for surgery. So let's come to history. It's more or less similar to the flap-based procedure that we are used to. Smile is FDA approved for 22 years or more. Younger age group, refractive instability, of course, you have to rule out any refractive procedure. And contact sports with any risk of traumatic flap dislocation may be better suited for smile. And for occupational purposes, you have to take into account the restriction placed on the minimum UDBA or CDBA by the specific occupation and type of refractive surgery that they are allowed to undergo. Systemic history, the contraindications are similar to other corneal ablative procedures: pregnancy, lactation, uncontrolled diabetes, collagen vascular diseases, et al. And any medications that may lead to ocular surface issues, abnormal wound healing, dry eyes, again should be looked into before undergoing for refractive surgery. Refractive stability with the manifest refraction spherical equivalent of less than equal to 0.5 change over the 1 year has to be documented. Past or family history of corneal ectasia should be ruled out. Any contact lens usage should be looked into. Examination, again, smile at present is FDA approved for a myopia of less than -10 diopter, a manifest refractive spherical equivalent of equal to -10 diopter, and astigmatism up to 3 diopter. CE approval is up to a manifest refraction spherical equivalent of 11.5 diopters. Investigations, again, the topography, pachymetry, contrast sensitivity, a barometry has to be done to rule out any contraindications similar to any corneal-based refractive surgery. Percentage tissue altered is a relatively new index, and it's calculated in smile as lenticule thickness plus cap thickness by CCT, and the cutoff is 40%.
Manpreet, just hold on.
Yes, sir.
Can admin send a link to Dr. Rupal Shah? She's not got a link.
Okay. I've been able to join, sir. Thank you.
Thank you, Rupal. Yeah.
So coming to patient counseling, you have to address the patient expectations, because unrealistic expectations of a perfect vision or improvement beyond CDVA may not be fulfilled, and unhappy patient and unhappy surgeon may be encountered. You have to explain the surgical procedure, the various surgical options, their pros and cons in detail, the possibility of complications, potential implications, and answer all doubts and query preoperatively. You have to importantly explain patient role during surgery. The patient should be able to lie down flat during the whole duration, follow the surgeon instructions, fixate on the light, and avoid moving or squeezing his lids during surgery. This is especially important because smile is a low suction procedure, and the incidence of suction loss does decrease if you counsel the patient yourself and the patient knows they have to look at the green light, and then it will disappear during laser application and everything. So consent should ideally have been read and understood by the patient before signing, ideally a day before surgery, and the patient should not be sedated or pupils dilated while doing so. Coming to decision making. So the ocular surface stability, corneal nerve regeneration, and a lesser incidence of dry eyes is observed in smile. So it's a better choice for patients who have mild ocular surface disorders preoperatively but are still motivated to undergo a refractive procedure owing to the less subbasal corneal nerve damage. As you can see here, this is SMILE preoperatively, post of 1 month and post of 6 months with nearly a similar nerve pattern as seen pre-op. And in LASIK, you can see the nerves have not even started regenerating significantly. So flap-based procedures have a vertical transection of the collagen lamellae in the strong anterior and peripheral stroma and are said to be associated with greater biomechanical weakening. In addition, they have all the flap-related complications, dislocation, buttonhole, irregular flap. SMILE leads to a transection of the collagen lamellae only at the site of the cap side cut and preserves majority of strong anterior and peripheral collagen lamellae. So it is said to have superior biomechanical stability, though the results are still inconclusive because you have contradictory studies. Still, SMILE is said to be more biomechanically stable. The, then you have to look at the type and magnitude of refractive error. For now, SMILE is still 10 diopter of myopia and up to 3 diopter of cylinder. And it's not FDA approved for hyperopia at present. Those studies are still underway and it's made good progress and may soon be approved. For a lower refractive error and thin lenticule, difficult dissection in the early learning curve may be experienced. And for a higher refractive error, SMILE may be beneficial as it has better biomechanical stability. Coming to anatomical features and patient factors, deep set eyes, small palpebral fissures, anxious patient unable to follow instructions is more predisposed to develop suction loss as SMILE is a lower pressure system and may be more suited for flap-based procedure. Pupil size. So, as you can see, SMILE is less sensitive to a larger pupil size and has less higher order aberrations. This is a case of SMILE with higher order aberrations of 0.29, and this is a case of LASIK with 0.48 microns. So, patients with larger pupils tend to have more pronounced symptoms due to increased spherical aberration and may be better suited for SMILE. Enhancement and retreatment. There is no established protocol for performing a repeat SMILE at present, and you have to go with flap-based or surface ablation procedures or the circle pattern. So just to sum up, SMILE may be better suited for patients with pre-existing ocular surface disorders, high refractive errors, and contact sports. For hyperopia, higher astigmatism, post-refractive surgery, enhancement, LASIK or PRK may be better. So just a summary of the case selection for beginners. Avoid difficult cases like low myopia with resultant thin lenticules, difficult orbital anatomy, uncooperative, extremely anxious patient, high astigmatism where cyclotorsion compensation is desirable. Thank you. This is our book by Professor Tityal and me on SMILE surgical techniques and challenges, and will be very useful for beginners to go through. Thank you for your kind attention.